Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're glad you joined us. Before we begin, I'd like to thank our sponsors, Altman Health System, Studio Arts and Glass, and Genuor Appraisals and Liquidations. Today, Brad and I are broadcasting from our administrative offices, and our very special guest is Dr. Krishna, President of Diabetes and Endocrinology Associates of Stark County. Good morning, Dr. Krishna, and welcome back to the show.
Paul and Brad, thank you for inviting me to the show again.
Diabetes is an epidemic in the United States. Nationally, 37 million people, or 11.3% of the population, have diabetes and faces its devastating consequences. Here in Ohio, our statistics are a little worse, with 12.1% of the population having been diagnosed with diabetes, and an additional 33.6% of the population in Ohio has prediabetes. Diabetes puts patients at risk for serious complications, including heart disease, stroke, amputation, kidney disease, and blindness. Dr. Krishna is a professor of medicine at Northeast Ohio Medical University, president of Diabetes and Endocrinology Associates of Stark County, and he is also involved in its principal investigator at his site for various major multicenter clinical trials. This morning, we're going to talk with Dr. Krishna about the diagnosis and treatment of diabetes, as well as what's new in the field of diabetes. We'd like to remind our listeners that our program is also available on our podcast. You can download that from your favorite podcast app. Just look for Medicine Center Pharmacy, and you can listen to any of our programs anytime.
So, Dr. Krishna, welcome back to the show again. Please introduce yourself to our listeners and tell us about your practice.
Yeah, thank you. So Diabetes and Endocrinology Associates of Stark County, Inc. has served Northeast Ohio and surrounding communities since 1970, so like over 50 years. And I have been with the practice for over 27 years. I consider myself a practicing endocrinologist, a teacher, and a researcher. I enjoy this specialty and remain very optimistic because of the exciting developments in the field over the last 3 decades. Most of all, I enjoy interacting with my patients and the long-term relationship I have had with so many of my patients. Many of them have been with us for decades.
So, do you offer any other special services in the practice?
Yeah, so we actually provide a very comprehensive, high-quality endocrine care under one roof. In our office, we have licensed registered dietitian, certified diabetic educator, insulin pump trainer. We have a lab draw site. From diabetes management, we also do thyroid ultrasound guided fine needle aspiration of thyroid nodules, and see a wide variety of endocrine problems. As you mentioned, we also offer patients the opportunity to participate in major multi-center clinical trials.
Over the years, we've diagnosed diabetes in different ways. How currently now, 2022, how are we diagnosing, what tests or how do we actually diagnose a person with diabetes?
I think as such, the tests may not have changed very much, but the criteria or the cutoff ranges have changed over time since even I've been in practice. So among the various criteria, one is the fasting blood glucose. If it's 126 or more, that's one criteria. Hemoglobin A1C, which is like the average for the last 3 months, if that's 6.5 or more, that's also considered a diagnosis of diabetes. The 2-hour glucose tolerance test is still used at times. A random blood glucose of over 200 with symptoms, so just patient comes in, the sugar is 200, but having symptoms like excessive thirst, urination, that can be considered as a diagnosis as well. Now, once in a while, we need to distinguish type 1 versus type 2 diabetes because that may have a management decision point. So there are some specific blood tests called the immune markers for type 1, which can be checked in those cases.
How can patients monitor their glucose level? I know things have changed a little bit there.
Yeah, I mean, I think they've changed a lot and they're changing fast. So we've had the traditional blood glucose meters, And there's such a wide variety. You go to the pharmacy or grocery stores, the pharmacy section, so many of them on the aisle over there. There's a big variety among them, depending on the cost, convenience, and the type of data that is displayed. Now, more recently, well, actually recently, it's been many years now, that the CGM, which is continuous glucose monitor. I was thinking of a good comparison to highlight the difference between the intermittent finger stick checks and the continuous glucose monitors. So let's think of, we are following a game, any sports, looking at just a few snapshots taken at different time points during the game, and may not even be the most crucial times of the game, as opposed to watching a live telecast of the full game. So you get us so much more and are able to understand the dynamics of the game way better. And same way with diabetes. So the CGM sensors, or the continuous glucose monitoring sensors, which more and more of our patients are nowadays using, are two different kinds. One are the real-time sensors, and the other ones are intermittently viewed. What that means is, although they're all checking the sugar every few minutes and they're recording it, but the real-time sensors are constantly displaying it or transmitting it. It could be on a smartphone, it could be on a reader. So you look at that and you can see the trend, you can see the line. And the intermittently used ones, or the flash checks, that's when you scan your phone or the reader on the sensor and you can see what the reading is. Okay. So the real-time sensors, they provide the numerical and the graphical information to see the trend and the direction in which the sugars are going. You can program alerts in it. So if it's dropping too low or going high, it'll send an alert. They have been shown, I mean, just knowing more about our glucose levels has been shown to improve blood sugar control. And I think it's just more we see something, the more, I guess we can take action. Of course, the benefit of these is directly correlated to how often we use it. Do we use it persistently and frequency? Then it definitely helps. So that's about the sensors.
Definitely a lot of options. So that's at least good for meeting different patient lifestyles.
Mm-hmm.
So. Sure. Okay. The other thing that has really changed over the course of time is how many medications are available to treat diabetes type 2. And there's a lot of different injectable products also. So can you speak to the treatment options that are available to enhance patient care that are available today?
Yeah, so I'll first talk about the non-insulin treatment options. And as you said, it's just been an explosion of how many medications have come in for many, many years. I would say till about 2-3 decades ago, there were just 2 different classes. And now we have over 10 different classes of medications. And then among each of them, there are different generics, there are brand names. In addition, there are then the combinations. So they'll put two of those medications together. So it's great to have more choices, but it increases the complexity of management decisions. It has to be remembered, of course, that every medication comes with some advantages, some possible side effects, and not every medication is for everyone. Individualized therapy is the key in diabetes.
You're listening to Health Matters with the Medicine Center Pharmacy. Okay, it is the bottom of the hour and time for the news. You're listening to Health Matters with the Medicine Center Pharmacy.
Just the blood glucose lowering. Let me talk just briefly about the microvascular and macrovascular complications. So one is the small vessel disease, which is like in the eye, the kidney, the neuropathy. They're very troubling, uncomfortable, affect the quality of life, but they may not necessarily acutely kill. And then there are the macrovascular complications, the bigger vessels. So that's the heart and the brain. So strokes, heart attacks, and all that. So now the emphasis is, if a new medication comes out, they want to see, does it also cut back on the cardiovascular risk? Because that would really save lives. So I'm coming back to your question about, what's about the injectables. So there are 2 different categories anyway on the ones that improve the cardiovascular risk. One is the SGLT2 inhibitors. These are medications which cause loss of sugar in the urine and bring the sugars down in that way. And the other one, which now are usually the once a week injectables, they are called the GLP-1 receptor agonist injections. One of them is now also available as an oral capsule. And both these classes have been shown to decrease the cardiovascular risk, cut back on hospital admissions with congestive heart failure, and even strokes. And the SGLT2 inhibitors in some recent big studies have shown to be able to decline or cut back on the gradual loss of kidney function that happens with diabetic kidney disease. Because despite the best control of sugar, blood pressure, and using ACE inhibitors, ARBs, which is the current standard of care, once the kidney function starts declining, usually it still keeps going down. So we are still looking for medications that would help in that area. And talking again about these injectables and some of the other classes, weight loss or weight reduction is often a very important thing for diabetics. And that's where many of these are quite helpful. In fact, there's another injectable which just came out, which is a GLP-1 and a GIP-1 receptor agonist injection. So these are just, different incretins we're talking about, not going into detail, but that has shown a significant weight loss in addition to blood glucose lowering. So they just keep coming like every few months, if not every few years.
Other treatment options, I think that as scary as it can be to have a diagnosis with diabetes, one of at least the optimistic things you can look at is there's such a big variety of treatment options. You've talked about two classes with injectable or oral. Are there other treatment options that you'd like to talk about for patients that they can employ in helping control and be mindful of their diabetes?
If you're talking about options other than medications, then
or combined with it.
All combined.
Yeah.
So, I can go into different classes of medicines. Metformin still remains like the first line based on some of the guidelines. Then you have, of course, the GLP-1s, which I mentioned, the SGLT2 inhibitors. You still have the sulfonylureas. Cost is still an issue, a big issue. And the only two generics, really, most of them, are the metformin and the sulfonylureas. Then you have shorter acting secretagogues, which just cause release of insulin in a short manner, and they can be dosed with each meal. There are pills which slow down the absorption of the carbs, complex carbs, and blunt the rise. There's a cholestyramine, which again works in different ways. There's cabergoline, which works centrally. TZDs at one time, glitazones were used more, not as much now. So there's a whole class of medications, and I have not touched on the insulin as yet. So,
do you want to talk about insulin?
Yeah, insulin. I think it's a very interesting time to talk about insulin, and I like history of medicine. The reason I say it's a very interesting time because it's been 100 years ago that the insulin was first isolated by doctors Banting and Best at the University of Toronto in Canada in 1921. And Dr. Frederick Banting was a Canadian surgeon, and Charles Best was a medical student. And they successfully isolated insulin from dogs and showed that injecting this hormone in dogs who were induced to have diabetes brought down the sugar. So then they extracted more insulin from the pancreas of cattle from slaughterhouses. And on January the 1st, 1922, so 100 years ago, a 14-year-old Leonard Thompson became the first person ever to receive an insulin injection for treatment of his type 1 diabetes. And since then, millions of lives have been saved from a previously fatal condition, the type 1 diabetes. And after that, so that's the history. But then I would say almost for 75 years, probably not much changed. We had the NPH and the regular insulin, which we still have, some ultra long acting. And then I remember it was about, I think 2.5 decades ago that the first analog insulin came out. So analog meaning the insulin molecule is tweaked by the scientists to to work in some different way. It could be ultra long acting, like once a day, or much faster acting. And in fact, I had gone around the state, various physician groups, as talk about this first analog insulin which came out. And since then, so many others have come out. So they improve the compliance. You can dose it with the meal, and have helped. Among other insulins forms, an inhaled insulin is also available. It comes in a small capsule type of thing. It's like a whistle device. You press it and you can inhale that. It's a short-acting insulin. And then there are pre-mixed insulins, so long and short-acting insulins combined, and there are biosimilars insulin. So as you can see, it is just, again, an evolving field, and pretty exciting, and more choices for the patient as long as the prices and accessibility can be maintained.
You know, doctor, low blood glucose is a big concern for some patients too. Are there new meds to treat serious blood low glucose deals?
Yeah, so I think, that's a very important point. If a person is not fully conscious due to low blood sugar, and they're not able to take anything by mouth safely, then glucagon can be given by another person. And glucagon counters the action of insulin. So that's how that hormone works. So even if a 911 is called, which probably should be, then glucagon could help in those precious minutes when the person is unconscious due to low blood sugar. Traditionally, it's come in a glucagon kit, like a bottle, diluent, and a syringe. So the caregiver, whoever's administering it, would fumble and try to fill that up and give the shot. So now and you can imagine that it can be pretty stressful. So now it comes in a pre-filled glucagon injection device. You take off the cap, hold it to the skin, press the button, and it can be given. And there's another form, the intranasal glucagon, not glucose, glucagon, which you put it in the nasal area and then press it, and the powder gets absorbed. So I would just like to emphasize that if you have diabetes, and especially if you are taking insulin, then please keep a glucagon kit with some family member or coworker who can administer it in case of emergency. Hopefully it is never needed, but if the situation arises, it can be life-saving. If I would just take a minute, you had asked what's new in insulin, and I was just thinking of, I think it's very also interesting on how else the insulin can be given. Like, what are the delivery options for insulin? Is that okay if I talk briefly about that?
Absolutely.
Sure. Okay. Sure. All right. So, the traditional way has been the insulin bottle and the syringe, the vial and the syringe. Then came out the insulin pens, and it made it easier to dose, to carry with yourself on person. And then more recently, there are some smart pens which have come out. I mean, everything is smart nowadays. So they call it smart because it communicates with the dosing app on the smartphone, and it can help guide how much insulin to take, and you can track, like, did I miss the dose? Did I take it? And all that. Haven't used it a lot. Is that, more recent, cost may be an issue, but they are available. And then, of course, the insulin pumps, which we use quite a bit in our practice. The two different kinds. One are the standard pumps, which have a cannula. So it's like a pager type of device, which has the short-acting insulin. And like the human pancreas, it just infuses the insulin all the time. At the time of the meal, you take the bolus. And there's the patch pump, which can be stuck on and then changed every few days. We have closed loop systems. Closed loop meaning we talked about the sensors, we talked about the pump. So one is sensing the sugar, the other one's delivering it. So if they could talk to each other, that would be great. And so now they're able to communicate or talk to each other through Bluetooth technology. And if the sugar is dropping low, it tells the pump, cut back on insulin or stop the insulin. If it's rising, it can gradually tell the pump to go up. So they're trying to mimic what the pancreas does. Still not there. It doesn't know when you're going to eat and how much. So, it can't dose that. Also, the data from the pumps can be uploaded to the cloud. So when the patients come to our office, our nurses download the pump or the sensor, and we can get the information in a real-time way Sometimes patients would just call from home and say, it's on the cloud. Could you download and tell me, what to do? So I could be anywhere, and even through my cell phone, if needed, I can do that. The sensors are getting smaller, more accurate. They can be worn for a longer period of time, so all that, it's just, I can go on. It's just so exciting. But yeah, so those are the areas.
Very
It's
interesting.
amazing.
It is amazing. How about the American Diabetes Association publishes standards of medical care in diabetes every year? So are there any new areas where the ADA has been giving us any guidelines this year?
Yeah, so the ADA guidelines come out every year, and there are some changes every year. But interestingly, this year, the American Diabetes Association revised nearly all sections in the standards of care. This includes changes and recommendations for diabetic screening, diagnosis, prevention, evaluation, management, patient education, technology, glycemic assessment, weight management, care of special populations. I mean, it could be a whole topic like care of children with diabetes, care of elderly with diabetes. And they have emphasized a patient-centered approach, because see, that's so important to improve medication adherence and management. The guidelines also review social and financial barriers faced by patients. They also suggest resources in the community, whether it's in person or online, that should be provided to patients. So there's a lot, and if anyone's interested, in that, I think they can always go to the American Diabetes Association website and look at the guidelines that may pertain to their specific case.
Interesting. So what's the ADA's recommendation for screening the general public for diabetes?
For the general public, they mention that all adults, even without any risk factors, should have some test to screen for diabetes or pre-diabetes starting at age 35. Previously, the cutoff was 45 years, and this year they changed it to 35 years. They also mentioned that all women who are planning to become pregnant, especially if they have risk factors, should be screened to check for undiagnosed diabetes. And for any unplanned pregnancies, the women should be screened for diabetes at the very first prenatal visit. What has not changed is the recommendation to screen for gestational diabetes, which is diabetes that starts during pregnancy. So that's between 24 and 28 weeks of pregnancy, and that's not changed.
You're listening to Health Matters with the Medicine Center Pharmacy. I am your host and pharmacist, Paul White. This morning, Brad and I were talking with Dr. Krishna about advances in diabetes care. We have a lot more to cover this morning, so let's get back to the show.
Doctor, I heard something recently that was kind of an interesting juxtaposition of words, and I wondered if you could talk about what is hypoglycemia unawareness.
Yes, and this is, I think, thank you for raising that topic, because I think that's so important. Sometimes not always given importance or considered. Anyway, so hypoglycemia unawareness is the inability to sense a low blood glucose. That is the typical symptom. So if someone is having low sugars, they'll say, I'm having shakiness, I'm having perspiration, palpitations. But some people just lose that ability to sense a low blood sugar. And this is actually an urgent medical issue. This happens usually in long-standing diabetes with type 1 diabetics, and sometimes with type 2 diabetics with severe insulin deficiency. Just like, neuropathy, which can cause pain or lack of sensations in the legs, feet. So there are other nerves, which are the autonomic nervous system, and they can be affected. So the sensations or the input that goes to the heart or the other nerves is lacking. So even though the sugar drops, they don't get those symptoms. So now why that's so important is you may have to modify how aggressive you want to be in these cases. If you try to be very aggressive with the blood sugar control, then there is a risk of hypoglycemia. And that person will not be able to feel it. So you have to weigh the risk versus benefits. And on the new standards of care from the American Diabetes Association, they found that by relaxing the glucose targets, being less aggressive for a few weeks, it could improve hypoglycemia unawareness in some patients. I mean, in my clinical practice, it's been difficult. Those who have it usually just tend to have it, and I have to keep that in mind. Provide them, just like we were talking about glucagon, other things, kits, prepare their family members. Now with these sensors, that's very helpful, because I think the biggest concern is during the night when someone's sleeping. We don't know. Even without hypoglycemia unawareness, it may not be picked up. So with setting these alarms and things, we have some better tools. But yes, it's an important condition.
Well, you mentioned tools, and you're talking about some things that I find fascinating with the pumps and the smart pens and all these Bluetooth connected devices. And I have to also think about the challenges some patients may have in embracing this technology to help them manage their care. It's probably stressful enough to know that, okay, I just got a diagnosis of diabetes, and now, doctor, you want me to use a pump and my phone app and all these things. So how do we help patients kind of meet them in the middle so that we can take advantage of all these cool tools to help them, but not overwhelm them at the same time?
Yeah, no, absolutely. That's a great point. And I mean, I just think of it like every few years, they come out with a new version of the new smartphone. You have to go in, and I always hesitate because I may not be that conversant with the new technology, and my kids would say, "Oh, we can do this." So just like that, whether it's the smartphone or phone or television or computer or laptop you're getting, it's very important to have the patient's input, not just like tell them this is what it is, go on to this. It will not be helpful. Actually, it will be wasting resources and may do more damage in some cases. So the standards of care by the ADA emphasizes that patients and caregivers be involved in selecting the devices. That involves education, right? I mean, in some cases, we think this patient or he's very elderly, he will not be able to maybe handle that. And we are surprised they can do it. I mean, they are sometimes one of the best people who comply with it. So we have to educate, assess, and an ongoing training. So ongoing training is important, not just plug in the device and they're gone. Just like any technology, when we start using it, then some glitches show up, then we need some support, then we need feedback. And then you constantly evaluate their skills in using the device. Are they using it appropriately or not? There are other things just to keep in mind. For example, we talked about, like you said, all the continuous glucose monitoring sensors and all that. No technology is 100% foolproof. So even those with the sensors should always have a blood glucose meter with them, because in some cases, the finger stick sugar may be more accurate, especially when the sugar is moving fast. Remember, the sensor is not picking up blood sugar, it's picking up sugar from the interstitial fluid. So there can be a lag in between, which new technology is decreasing, but it's still not exactly the same thing. Same thing with the pump. I mean, it reminds me to, again, emphasize, if you have a pump, please make sure you carry an insulin syringe or an insulin pen. Because I once in a while get calls over the weekend or nights. My pump's not working. I've called the company. They'll ship it in 24 hours. What do I do now? So as long as you already have the insulin. So if you have a device to inject the insulin with something, you can carry over. And so I think, yeah, so you're right. I mean, that's very important.
I really like your tip on having a backup method if you have an insulin pump that has a glitch. That's an important lesson I need to make sure our pharmacists share with patients. So thank you for that. You also mentioned some complications earlier in the show that patients can have based on their diabetes status. And I wondered if you could talk about how, depending on the type of diabetes and the type of complications patients have, how does that affect the choice of the therapy that you prescribe a patient?
As I mentioned, diabetes therapy is so individualized. Like many times my medical students, residents would come in and say, what's the flow diagram? How do we go? There are certain flow diagrams, but it is really patient dependent. And comorbidities, which means other medical problems apart from diabetes that specific individual has, and other complications. Maybe someone has had pancreatitis, has kidney failure. So that will limit the use of certain medications. Now, while metformin has been the first line choice all these years, and it still is in many cases, but now the SGLT2 inhibitors and GLP-1 agents that I mentioned, it is recommended can be considered if someone has known heart disease and has had a heart attack, heart failure, chronic kidney disease. So one has to give thought to, can we use these medications? Will their insurance cover? Can they afford it? If so, if there's no other contraindication, this may provide some additional benefit. Weight, we talked about, so that could be a consideration. I mean, in my clinical practice, sometimes profession is an important thing. I mean, we have truck drivers interstate where there are certain restrictions on they can't use insulin, so you have to choose on certain things. It could be an airline pilot, it could be. So how much risk of hypoglycemia can you endure? How aggressive can you be? What's the age of the patient? The cutoffs for the glycemic control, like the hemoglobin A1C level in the elderly, it used to be, bring it down. Now they're saying maybe 8% may be okay because the lower. So all those factors come into place. I just mentioned about pancreatitis. It's just like if someone has had history of pancreatitis, then in many of those cases, you would probably prefer to avoid the GLP-1 agents and the DPP-4 inhibitors. I'm not using the brand names, but just the class names. And again, if the kidneys function is markedly impaired, you can't use metformin. And below a certain level, you can't use SGLT2 inhibitors. All those factors come into play. So, and patient choice. It could be a person just says, no, I'm not going to take injectable. We work with them. We just don't give up. Show them how to do it. And many a times, they will finally agree, maybe not on the first visit, but the second or third. But if they still refuse, there could be other options. And we just keep exploring and do the best we can for the patient.
Last commercial break is here. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White, and thanks for joining us today. Let's get back to the last segment of the show. Doctor, it's like we're not making any headway with this disease. Is it just because we keep diagnosing more and more people, more and more patients with this disease who, aren't taking care of themselves, don't know how to take care of themselves? I don't know. What do you think?
I think yes, it is a little disappointing that I'm talking about all these exciting things and new medications coming out, but have we really made a headway in terms of decreasing the average A1C in the country? Have we cut back on the number of cases in the US and across the world? I think it tells us how complex the disease is. Just the fact that there are so many different classes of medicines, and each one of them, or most of them, are working at different sites to control the diabetes. So what does that tell us? It tells us that what's causing diabetes is the multiple things in the body. It's not one thing. And that's why the research is also, we think it's still just the tip of the iceberg. And that's what makes it complex. I think, of course, our lifestyles. It's a lifestyle disease. Some people feel increasing obesity. All those things complicate. Some things, yes, you can have insulin delivery devices and all that, but if you don't manage your diet, you'll just keep going up and up on insulin. You go up on insulin, more insulin, the more the weight gain, then you counter with some other medication for that. So it can become a vicious cycle. So I think we have hope. If we did not have these medications, things would have been worse. But you're right that in some ways, overall, it's not as great as we would have liked it to be.
What you're saying is that diabetes is sort of like a cancer, because cancer has many causes and many treatments, and we keep saying, well, we're gonna solve that cancer issue, and we keep saying we're going to solve the diabetes issue. So they're kind of like, look at the progress we've had in heart disease and some of the other really life-saving, events. And I know we've made progress in diabetes, but it just, I don't know. It just seems
No,
like.
so if I can just add, one other thing is how much funding have we put in diabetes care, and as opposed to any other conditions, because they are felt to be like just going to kill right, now, like heart disease, and people have symptoms. I'm having chest pain, you rush to the ER. Diabetes it's going on. I mean, I don't know what's happening. So the funding has often not been there, and education, especially when I say funding, it's not just physicians or hospitals, but education is so important. Diabetic educators, they're so important, and often there's not an insurance coverage for it, and patients don't get that. Till you have that, you miss out on a big thing. The other part is, which I'm seeing, which is a good thing now, you have all these huge big technology companies, but they really haven't invested in diabetes care technology over all these decades. Maybe it wasn't that lucrative for them. But now look, like all these big companies, Google, Apple, they are the ones who are putting in the money for these sensors, for these pumps, for these cloud, for all that. So that to me is a hopeful sign, because if money is flowing through, and if the technology, we can keep it accessible to the patients, and that's another big topic. That's I think that's hopeful, because finally, and same thing with clinical trials. If you need funding for clinical trials, the more trials you have, you get better medications, and you. So yeah.
Interesting.
So you mentioned clinical trials. It's actually exciting to hear that in our community, you're participating in clinical trials. Can you talk on how that research happens at your practice?
Oh yeah, so thank you for mentioning that. So this is a very exciting area for me, and I'm very passionate about research, and we've been an important site for clinical trials for the last many years. So I have a clinical trials unit. We have some dedicated clinical research coordinators and the principal investigator. We have a sub-principal investigators. All these medications which come out, they have to go through trials. And when we say multicenter, which means there are multiple centers across the country who are good in clinical research, who are chosen, and that's where the trials are done. Some of them are blinded, which means you don't know if you're using placebo or not. It could be, we take part in multinational trials, national trials. And the standard on the protocol is the same, whether the clinical trial, that trial where we are involved with, is being done at Harvard or at Cleveland Clinic or at our site, is the same, because there's that data finally has to go to the FDA, on which they make the decision. So we have been doing, and I focus on endocrine trials, although we have the ability to do other trials as well. And not only does it keep me interested, involved, mentally, up to date and sharp, and gives me diversity, but the patients, so many of our trials, our patients have benefited a lot, because the medication is free, the testing is free, those visits are free, and they're able to get a medicine which is not available now. Or if it was a phase 4 trial, which means the medicine which is already in the market, but we're trying to study some other benefit from it, so they get it at a discounted price, and there's learning. And many patients do it from just the standpoint of helping science. So it's an important field, and I can talk a little bit more about the trials that we are involved in.
Please do.
Yeah, okay. So for example, we talked about analog insulins. So the insulin previously was NPH, which works 8 to 10 hours. Then we came up with insulins, which are in the market, which are once a day insulin. Now we're working on several trials, which is for once a week insulin. So that's injected and it just stays in the body for 1 week. We have a couple of trials where it is on oral insulin. So it's in the form of a capsule. And, so if that is successful, that'll be great. We have a few trials on combination of the once a week insulin with the once a week GLP analog agent. So we talked about that GLP-1, which helps cardiovascular risk. So that's given once a week, but your insulin was once a day. If you could combine the once a week insulin with the once a week injection, maybe at least in some patients, just one shot a week might do it if they don't need the short acting insulin. We are studying medications which help in slowing down the kidney and cardiovascular risk. In fact, some of the recent big studies, they were published in New England Journal of Medicine, and they are actually changing the standard of care now. Those are the mineralocorticoid receptor inhibitors to protect the kidney. We were part of that study, and we were our site was acknowledged in the New England Journal of Medicine. And then we have studies on medicines for diabetes and weight loss, and so on. So studies come, we complete them, go on. Right now, we have a study from the Google where we have these high-tech cameras and 2 full rooms of cameras, retinal cameras, which are taking pictures of the retina and using the artificial intelligence, trying to see if it can pick up diabetic retinopathy pretty close to what an ophthalmologist, a human being, could do it. It's not to replace the ophthalmologist. The purpose is that it's not easy to access an ophthalmologist in every area of the country or the world. So if these things were there and they could screen, they could pick up the high-risk patients, and then they could be referred to ophthalmology. So I think that's really very exciting as well. So there's a whole bunch of studies that we are doing in our practice, and we're really excited on that. So
some time ago, there were islet cells being transplanted. Is that something that just has kind of gone by the wayside, or?
No. So that, thank you for raising that point. I think when you had asked me about, what else is new, I should have probably meant, or what other options are there. So we have, the pancreas transplant option, which is there, where the whole pancreas is taken and transplanted. Now, there are, limitations. It's a selective cases which are done. The bigger the tissue you transplant, the more the chances of rejection, right? Because the body responds to that. So the question is, if you're just dealing with diabetes, then why not take out the islet cells, which are the cells which produce insulin in the pancreas, and just transplant those? So that's still being done. It's been many years ago. It was in Canada, but the first very successful study was done on the transplant, and for almost 1 year, most of those patients did pretty well. So it's still available. And once in a while, some patients are very keen, and I refer them to some tertiary centers for evaluation. So that's there. And then not to forget about the bariatric surgery. There's a whole variety of bariatric surgeries, and there are studies. There was one done in Cleveland Clinic, the Stampede study, where it was found by certain bariatric procedures and losing significant amount of weight, it actually cured diabetes in some of the type 2 diabetics. So I have many patients with type 2 diabetes who've had, bariatric procedures, and they have benefited. We don't obviously do that, but we have the weight loss program in our office, and some patients have lost a ton of weight, and their insulin requirements have dropped. They've gone down from the U500 more concentrated insulin to very small doses of insulin. So that begins, comes to what Paul was mentioning, that things are in some way not as great, but I think change in the lifestyle, education, help can really bring down the diabetes.
Well, Dr. Krishna, we appreciate you taking out time to join us today. Can you take a moment and share your contact information with our listeners?
Yes, so our address is the Diabetes and Endocrinology Associates of Stark County. We are located at 4565 Dressler Road Northwest, Suite 111, Canton, Ohio 44718. Or you can call our phone number 330-493-0013, or learn more about us and contact us on the web at www.gotoendo.com. That's GOTOENDO.
Any final takeaways, doctor, for our listeners today?
But I mean, in the end, I would just like to say that I empathize with patients and their families who deal with the challenges of diabetes every day. But I also strongly feel that these are hopeful times with new medications and new technologies coming to the market and many more in the clinical trial phase. I also, I think, lastly, want to emphasize that diabetes management is a team approach, that the most important part of the team is you. I mean, if you have diabetes, and you play a crucial role in achieving a successful outcome. So we depend a lot on you. It's a team effort, but you are the most important. You determine whether we'll succeed or not.
Thank you to our guest, Dr. Krishna, President of Diabetes and Endocrinology Associates of Stark County. We'd like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. And thanks to our sponsors, Altman Health System, Studio Arts and Glass, and Genuine Appraisals and Liquidations. As always, we thank our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we will see you next Friday right here on News Talk 1480 WHBC.